let Lisa take over.
Hi, Dr. Sokol.
Hi.
All right, everybody listening in this morning, I am going to be introducing our third presenter. So for everybody in the audience, whether you have years of experience under your belt or if you're simply just starting out, there will no doubt be a time in your career where you wonder, in some cases, how a neurologist is thinking. I know there have been some times in my life personally where I've been amazed at a diagnosis or a treatment plan or just in awe of a difficult patient situation that was resolved by a neurologist. Today, Dr. Sokol is here. She's given us her time to help us answer the question of how, when it comes to how a neurologist thinks. Dr. Sokol is affiliated with IU Health Riley Children's Hospital and is an associate professor of clinical neurology and pediatrics. She's a board certified neurologist, epileptologist, and has her degrees from Purdue University and IU School of Medicine. Her clinical specialties are epilepsy and spasticity. She also does research in autism and has been listed among Indianapolis top doctors for several years now. Thank you, Dr. Sokol, and we look forward to hearing your presentation.
Can you see me or no?
Yes, we can see you.
See me? But I can't see. I'm going to get out of here. I mean, I'm afraid.
If you share your screen, if you click and share your screen, then you'll go away.
Now, is this what you want to see?
You can share your screen and you can present your slide deck.
But I don't have a slide deck.
Oh, you're just going to speak.
Well, yeah.
Okay, go for it then.
Now,
Can
you see me here?
We can.
Okay. Sorry.
That's all right. We'll just look at your beautiful face.
All right. We discovered just this morning that when I use my dry erase board, the letters are switched. So I'm going to ask for your help. So what I'm going to ask you to do is everybody get out a piece of paper and a pencil. And that will be your screen. And I will walk you through some of this presentation. The talk today is going to be very low level. Okay, I don't mean to embarrass anybody or make anybody feel bad, but many of these concepts I really didn't understand. And it took years to understand some of these, and much of my knowledge was like Swiss cheese. And so now I'm hoping to fill up some of the holes that you might have, as I did when I learned these things through the years. This topic of thinking like a neurologist came because I had a very intense chairman of neurology, Dr. Biller, and he told me, you're thinking like a pediatrician, you have to start thinking like a neurologist. And as a pediatrician, I would always memorize things, but as a neurologist, you have to process things. And I hope that we can try and learn how to do that together today. Okay, so I'm going to draw on my board and show you the drawings, but I can't show you anything that's written because it'll be backwards. Brain. Okay, the interesting thing about the brain is that it's mapped out in a very specific way, as you all know. But the interesting part for me was that the back of the brain has to do with information coming in, and the front of the brain is information going out. And that's also true of the spinal cord, where the sensory information is in from the back, and the motor information goes out from in front. And this is true in the cortex, and it's also true in the white matter. And don't forget, the cortex has to do with thinking, and that's where we have our higher cortical function, and that's where seizures occur. And the white matter has to do with tone and how we move, and that's where movement takes place. And the white matter is white because of the cortical spinal tracts that are encased in myelin. And so you've heard of the sensory motor strip. It should really be called the motor sensory strip, because where it's at in the brain it's reversed. The motor is in front of the sensory. And so you start with the pyramidal tract in the cortex. It comes down, it dives down in the posterior limb of the internal capsule, crosses over in the medulla. It goes into the spinal cord white matter. And that's where we have our cortical spinal tract in the spinal cord. It talks to the lower motor neuron. The lower motor neuron is the final common pathway out of the CNS. It goes to the plexus, it goes to the nerve, it goes to the neuromuscular junction. It gives a squirt of acetylcholine on the muscle, and that's where, and this is the pathway to spasticity, okay? So what happens is we see many patients that have a problem upstairs. They have a problem in their brain. There's a disruption in that pathway. And so their tone is in overdrive. Everything is in overdrive, pushing it forward. So there are many treatments that we use to try and cut this spasticity to reduce the tone that's going on down below. So we know that the seizures occur in the cortex, and as an aside, we'll use our anticonvulsant medicines that affect up here. But we use many of the other medicines that you see children on down below. So we use diazepam to help spasticity in the spinal cord. What happens is that there's a reverberating loop. There's a communication between the lower motor neuron and the cortical spinal tract. And when this thing doesn't have the connection up above to turn it off, there's an overdrive of spasticity. So we work at the spinal cord level with diazepam to try and help that reverberating loop. We use Valium there, that's diazepam. We use baclofen, works at the spinal cord level. We use Botox that works at the neuromuscular junction. It prevents acetylcholine from getting to the synaptic cleft. We use dantrolene at the muscle level to try and reduce the tone. So this is a model, a heuristic model of spasticity. But we'll go further in terms of what we learned from this model. We say that the information going in front, we remember that our Broca's area is in front of Wernicke's area that's on the side. Wernicke's area has to do with understanding information. So that's kind of information coming in from the back. I understand my world from the back of my brain. In the posterior temporal lobe of Wernicke's area. In the frontal part of the brain, I affect the world. I'm going to do my motor strip, but I'm also going to speak. Broca's area is the ability to speak, right? I don't understand, but I can still speak. Now, it's so interesting. Do you know that learning problems are more prevalent than epilepsy? They're more prevalent than autism. They're more prevalent than strokes. And so reading problems are a part of this. And the ability to read out loud is in the front around Broca's area. The ability to phonemically sound out the word is in Wernicke's area. And that, if you cannot sound out the word, by definition, you have dyslexia. So it's so interesting that not only do we have things that we've heard about every day, but also reading is important, and it's very close to these areas that we talk about every day. Now, reading wouldn't be accomplished unless you had the occipital lobe, where we have visual information coming in. And what happens over here is that you have a little lexicon. You have a little dictionary area that supports reading, that allows you to keep the words there so that they're quickly accessed. So that every time you read a word, it's not a new word. You can access it through your lexicon in the back of your brain. And of course, all of these areas are hooked together by the white matter tracts, by not only, well, not really the cortical spinal tracts, because that's more motor, but the white matter tracts allows you to hook these areas together. So if you've had a problem, for instance, with your white matter tracts, for instance, in prematurity, there's a much greater problem in reading you're going to have. And you're going to also have, because there's so many white matter tracts in the frontal area, you're going to have a problem with attention, because that's where attention is accessed, in the front part of your brain, so that you can affect the world. Okay. I wanted to make the point that two things have to happen for you to have loss of consciousness. Okay. Two things equal loss of consciousness. Either something has to go on with both hemispheres, like here. This is my axial cut of my MRI. Something has to happen to both hemispheres to have loss of consciousness, or something has to happen to the brainstem. This equals loss of consciousness. Now, why? Because the reticular activating system runs through the brainstem, and that keeps you awake. So if one of those things are aberrant, then you have a problem with loss of consciousness. So for instance, you have a 3 Hz spike wave discharge going through your both hemispheres, right? If it lasts for 2 seconds, by definition, you've recorded an absence seizure, and that's loss of consciousness. Okay, so 2 pathways have to happen, and that's going to be helpful for our next exercise. Okay. And let me just take a step back and say that the whole problem in adult neurology is to find the lesion. That's what we spend a lot of our time with, is where is the lesion, so that you can then understand the process to figure out the patient. But in pediatric neurology, of course, it's much more complicated. And the problem there is not only where is the lesion, but when did the lesion occur? And after we finish our talk, I hope you get a better sense of when do these lesions occur. Okay, so we're going to talk about 3 common scenarios that you're going to see with your patients. And we see this again and again in neurology. Now, the first scenario is going to be a sudden change. Anytime there's a sudden change, it's most like for instance, a sudden focal neurologic deficit. That's going to be a stroke, okay? Now, can it be a seizure? It can, but usually that's paroxysmal. It happens again, over and again and again, right? But a sudden change is going to be a stroke. And what often comes into the ER is you can have your leg more affected than your arm, more affected than your face, or you can have your arm more affected than your leg, more affected than your face. That's the second scenario. Or you can have your arm equally affected to your leg, equally affected to your face, okay? But anytime you're coming in with such a deficit, you know it's going to be a stroke. A tumor would be a gradual manifestation of these signs, okay? So let's talk with the first scenario. And let me just take a moment here and get an eraser. Okay. To understand this, of course, you have to remember the homunculus in these 3 scenarios. These are axial cuts of the MRI. And if your leg is more affected than your arm, more affected than your face, of course, your stroke is going to be in the contralateral ACA distribution, because the way the homunculus sits in the brain, the legs are on top, the arms are in the middle, and your tongue is, of course, is on the midline. So if let's say my right leg is affected. If my right leg is affected, then my contralateral side will be lost, or will be having a stroke manifested in it, usually a triangle-shaped lesion, okay? So that's easy, right? So let's take it a step further. Let's say somebody comes in with a problem that they can't control their urine. They can't, they're having problems with walking, okay? And they have problems with headache. Okay, now look what's happening there. Something is going on in this area, is that right? So this is now probably the development of hydrocephalus, because the ventricles are going to be enlarging in the front, and that's going to be affecting their walking. The micturition center is here, volitionally able to urinate. That's going to be affected. And anytime you have a mass in your head, that's going to be a headache, right? So expanding on this homunculus, you can start understanding why people present the way they present. This is, of course, in an adult. Now, let's say that the right arm has now more affected than the leg, is more affected than the face. Well, the homunculus applies again. This is, again, my axial cut of my MRI. And in this case, I'm going to have a left MCA distribution stroke, middle cerebral artery, whereas the above was anterior cerebral artery. Now I'm down to middle cerebral artery, and it's going to be on the right side, so the stroke is on the left. Now, it doesn't end there. Usually what you see with this is you could see a problem with Wernicke's aphasia. Is that right? We're seeing that because remember, the speech center is on the left side of the brain. But it doesn't end there. You're going to have a visual field defect. And this, by definition, is how the ophthalmologists look at they write their notes showing the patient's visual field. And you're going to have a visual field cut that is on the same side as the deficit. You're going to have a right homonymous quadrantopsia, known as pie in the sky. And that's how the ophthalmologists write it, because that's the area that you can't see. So that the lower tracts cause this pie in the sky deficit, whereas a parietal stroke would be a low pie in the sky deficit. Okay, and the reason for this is that the optic nerve comes in, crosses over in the chiasm, goes through the optic radiations that are in the temporal lobe, and that's why your MCA is also in the temporal lobe, and that's why you get that cut. And then the optic radiations go to the back of the brain. And so you'll see this pie in the sky lesion associated with a left MCA stroke. It doesn't end there though. You're going to have a central 7. You ever heard of a central 7? That's when you have a depression of your nasolabial fold, but your frontalis muscle works fine. The right depression of the nasolabial fold will be on the same side as the weakness on the right side, and it will be on the same side as the visual field cut, all on the right with a left MCA stroke. This is known as a central 7. If you had a problem with your frontalis, you couldn't lift your eyebrows, and you had a depressed nasolabial fold, that would be a peripheral 7. That would be a 7-nerve cranial palsy. You'd be in better shape that way than if you had a central 7. That's more deleterious. The central 7, if you have a central 7, the lesion is at or above the level of the pons. I'm going to say that again. If you see a central 7 on your patient sitting there waiting to get into the scanner, the lesion is at or above the level of the pons. And we'll come back to that because I want to tell you about the rule of 4s. These neurologists love these rules. Okay, so that's about it for the left MCA stroke. Now, let's say a patient comes in, their leg is as affected as their arm is as affected as their face, and it's a sudden change. But they're able to talk, and they're alert. Okay, where is the lesion there? Well, you have a dense hemiparesis. And sometimes this hemiparesis can get quite spastic, okay? But they're alert and they can talk. Now, some people say, oh, heck, maybe they have a big clot in their ICA, their internal carotid artery, that's going to impact their ACA and their MCA. The problem with that thinking is that if you had such a huge stroke like that, you would have midline shift of your brain and both hemispheres would be involved. And that way you couldn't talk. That way you would have loss of consciousness. Why? Because of the rule we told you before. If you have both hemispheres involved, you have loss of consciousness. So that's the wrong answer. So the right answer has to do with the posterior limb of the internal capsule. And you have to understand how the cortical spinal tracts are splayed on the hemisphere. So here you have your hemisphere, and you have your cortical spinal tracts on the surface of the hemisphere, and they swoop down and they get small in the posterior limb of the internal capsule, but they maintain that homunculus where you have your leg, arm, and face, but in a very tiny pattern until it dips down, crosses over in the medulla, and dives into the spinal cord. So at the site of this lesion in the posterior limb of the internal capsule, it's a very small lesion, but it's caused by a very intricate area called the lenticulostriate vessels of the lateral MCA, of the left MCA that come off of the MCA. That can cause a very dense stroke. And these lenticulostriate vessels are small. And if you have hypertension, they could pop. And so you could actually have a hemorrhagic stroke. And of course, a hemorrhagic stroke is always worse than an ischemic stroke. Why? Because you have blood in the brain, and blood is highly epileptogenic. Watch out for seizures if you have blood in the brain. These lenticulostriate vessels can also be ischemic, cause ischemic stroke. They can be a source for atherosclerosis. If you have diabetes, all these problems can cause an ischemic stroke, which usually they fare better than a hemorrhagic stroke. Okay. So it can be a very tiny stroke, cause a very big problem. Now, I mentioned that the whole point of pediatric neurology is not only to identify the lesion, but to say, when did the lesion occur? And something very interesting happens in children. They start developing their myelin at 5 months gestational age. So that if you get a lesion after 5 months gestational age, you could have this condition called periventricular leukomalacia, which literally means a thinning of the white matter around the ventricles. You've heard this, you've seen this in your patients. Okay, here's my axial cut. I don't want to forget my homunculus with the legs in front, the arms in the middle, my tongue underneath. And what happens after 5 months gestational age, you get decreased blood flow around the area of the legs. Why? Because kids don't have, these premature kids do not have, they have a pressure passive system. They cannot regulate their cerebral blood flow. So anything that happens down below goes right up to the brain. Now, when my husband makes me mad, my blood pressure goes up, but it doesn't go right to my brain because I have a pressure resistant system. I have a mature system for my cerebral blood flow. But these children do not have that. So whatever happens down below, or what doesn't happen down below in intrathoracic pressure, if you don't get enough blood flow, it's not going to get to your brain. And that's what happens in these children that have periventricular leukomalacia. This is a problem with the anterior circulation. And what happens is that you don't get enough blood flow to the anterior cerebral artery, middle cerebral artery watershed area in between here. Why? Because these kids are dehydrated when they're born. Dr. Engel and the neonatal unit says, give fluids, give fluids, give fluids, because these kids can't do it themselves, right? And so many of these children come out without enough perfusion in this critical area, this watershed area. So guess what? They're going to get a scar here. The corticospinal tract will scar down and cause periventricular leukomalacia, meaning thinning of the white matter around the ventricles. And look where this is affecting the legs, okay? And so that's why majority of kids that have premature, they come out with spastic diplegia. In other words, they're toe walkers. They'll also have problems with attention. Why? Because those white matter tracts are used in the frontal lobes to help pay attention to information. So they often have learning problems. So over 5 months of age, they're at risk to have this scar in the brain, periventricular leukomalacia. They don't get enough perfusion. The other problem that you see is that they can have this condition called intraventricular hemorrhage. In other words, they can have blood in their ventricles. Same idea. There's now there's too much perfusion. So what happens is that there's blood, there's vessels that are around, this ventricles that are known as the germinal matrix. These vessels are very vascular. And the heck of it is, if they could have only waited to full term, these vessels go away so that an intraventricular hemorrhage is not a problem. It's just the biggest irony of prematurity. If they could have only hung on till 40 weeks, you wouldn't even have this problem. Anyway, there's 4 grades of intraventricular hemorrhage, but in this case, what happens is that these blood vessels get too much pressure and they pop, and so the blood goes into the ventricles, making the ventricles bigger. This is a venous process. So for instance, if you have intraventricular hemorrhage that makes your ventricles bigger, then you've acquired hydrocephalus while you're a premature baby. Okay, and that's what they do. They follow their OFC, and they get, if it's bigger and bigger and bigger, not only do they have seizures, but they have hydrocephalus. okay? And so when they come out, they're going to have spastic diplegia because of the periventricular leukomalacia, which is the #1 neurologic sequelae of prematurity. I'm going to say that again. The periventricular leukomalacia is the #1 neurologic condition associated with prematurity. But the kids that have the intraventricular hemorrhage can also come out triplegia. Why? Because that expanding ventricle also affects the MCA distribution. It affects their arm, where the homunculus sits in the cortical spinal tract. So they come out without use of the arm that's on the contralateral side, and they can also be a toe walker. Okay. Now the irony of this happens again after 5 months gestational age. All this is going on while the kid is being surviving, right? Now it used to be when I was in training, 24 weeks was the max. Now we have kids 22 weeks that are surviving. So the thing is, many of the things that are happening in the neonatal unit are probably causing this. So intrathoracic pressure goes up, causing increased pressure to your brain that causes the hemorrhage, with things like if the baby is crying, if you have repeated IV sticks. At a teaching hospital, everybody gets a shot at intubation. We're all intubating, learning how to intubate. And with all of that, the intrathoracic pressure goes up. You have increased problems in your brain that way. Okay. So these are early lesions that cause problems that a pediatric neurologist wants to know about to be able to say when the lesion occurred. When you're seeing a mother, she wants to know, when did this happen? I just saw a mother yesterday, had to give her bad news, let her know when this happened. Now, the curious thing is if your lesion occurred less than 5 months gestational age, you won't come out with spasticity. The myelin is laid down at 5 months gestational age. If you disrupt it, if you cause a scar in it, you'll come out tight. You'll come out with spasticity. If you have a lesion that's earlier than that, at less than 5 months gestational age, you'll come out weak. You don't even have enough white matter to cause any tone problems, but you'll come out weak. So things that come out with weakness or hypotonia occur at less than 5 months gestational age. Things that can occur like this would be congenital hydrocephalus. It could be a spina bifida. It could be neurofibromatosis, things that occur right in the beginning. You can sometimes have weakness with that instead of the scar that causes the spasticity when they get older. So that gives you a little flavor of pediatric neurology. Okay. Now, I'm going to give you the rule of 4s. Okay, so I'm going to ask you to use your pencils and use your paper and write these numbers down, okay? 1, 2, 3, 4, next row. 5, 6, 7, 8, next row. 9, 10, 11, and 12. And then put marks like this between the numbers. And this is a magical little theory. It gives you localization power, okay? So for the first tier, you're in the midbrain. For the second tier, you're in the pons. For the last tier, you're in the medulla. Did you know that the medulla means a bulb? It's the bulb of the spinal cord, okay? This is a powerful tool. With this tool, you can figure out where the lesion is. These are the cranial nerves. These are the cranial nerve nuclei, and this is where they sit in the brain stem. The brain stem is about the size of a walnut, but it's perfused by different areas. Is that right? And so depending on what the patient looks like, it can tell you where the lesion is that could have a different distribution of perfusion. Okay. So cranial nerve 1 is the olfactory nerve. Cranial nerve 2 is the optic nerve. Cranial nerve 3 is the cranial nerve 3 is the oculomotor nerve. And cranial nerve 3 has a big job. It constricts the pupils. Cranial nerve 4 is the superior oblique nerve. And all it does is that it moves the eyeball a certain way is all that does. Okay. So when I think about the first tier, the midbrain problem, where the nerves sit, I think about a patient that came in when I was a fellow. And this was before the days of internet. All we had was our Harriet Lane in our pocket. And this kid came in with meningitis, and he had bad meningitis. And Dr. Kleiman, who's the infectious disease doctor, in on a weekend, this is a Sunday, and all bad things happen on a Sunday. And he left the ER, we were sitting there, he left the ER saying it's going to be a bad outcome. He was basing his opinion on the high protein in the CSF. The protein in the CSF was sky high. Okay, so we were just sitting there waiting for the bad outcome. The child had a seizure. I called the EEG techs in, they came in. Now remember, these days they weren't upstairs, they had to come in, do the EEG on a Sunday. Okay, the EEG showed moderate diffuse slowing. It didn't show seizure activity. Okay, we got a head CT before that. The head CT was normal. They did the LP. That was when they had that bad protein in it. Okay, so the seizure was short, 5 minutes. I loaded with phenobarbital, 20 per kilo phenobarbital. I came back a couple hours later to look at him, and he was doing this. He was in his bed. Of course, he had the arm board on. He had the IV in his arm. But I noticed he was having a kind of a jerk like that. And it was kind of a random jerk of his extremities. And of course, the parents were sitting in the room saying, oh, you got to do something. He's our only son. And so there was a lot of tension in the room. But I saw those jerks. So now what do? What could these jerks be? He just got loaded with phenobarbital. What do? Do I call the EEG techs in to see if this is a seizure? Don't want to do that. It's a Sunday. We didn't have 24-hour EEG. They weren't very happy with me as it was. I already called them in once on a Sunday. What could these episodes be? I was so far off on this patient. I was a fellow at the time. I thought, did I give too much phenobarbital? Maybe I gave too much phenobarbital. I remembered that maybe if you give too much phenobarbital, you can actually cause seizures. I looked in his eye. His eye showed a triangle-shaped pupil. Have you ever seen a triangle-shaped pupil? I haven't. So what could this mean? Funny hand movements and a triangle-shaped pupil on one eye. Can seizures cause a change in pupils? Sure. Could I have maybe given too much phenobarbital and caused this? Oh, could it be? I wasn't sure. I called poison control, and lo and behold, if you look far and fast enough, you can find any justification for your thinking. And they said, yes, it's a possibility. He could be having more seizures with phenobarbital. And yes, phenobarbital can cause dilatation of the eyes. I was so far off. What this was, he died the next day. What this was is the meningitis caused swelling of his brain. It impinged on cranial nerve number 3 so that he couldn't regulate his pupil, because the function of cranial nerve number 3 is that it constricts the pupils. He was having decerebrate movement. This is decorticate movement up by the cortex. This is decerebrate movement. The reason for that is that in the midbrain, there is the cerebral peduncle that houses the cortical spinal tract. And this cerebral peduncle has to do with movement. And so when your brain swells, there is a tentorium that allows your brain to the spinal cord to stick out. So here's the brain stem, here's the spinal cord, and here's the tentorium. Kernahan's notch. And when the brain swells, the brain comes down through Kernahan's notch. And so Kernahan's notch impinges on cranial nerve number 3 and impinges on the cerebral peduncle that causes those decerebrate decorticate movements. And it makes your cranial nerve 3 not able to react like it should. So you can have this correctopia, which is a name for an unusual shaped pupil when you're herniating. So basically this kid herniated and died with that, but I'll never forget that kid with this. And I always talk about it when I'm talking about this exercise. Okay, going down to the pons. Remember we said in the pons, we said that if you have a central 7, the lesion is at or above the level of the pons. That's because the cranial nerve 7 nucleus is in the pons. And just so if you have a central 7, the lesion is at the left or right MCA distribution, which is above the pons. Okay. And cranial nerve 5 is V1, V2, V3. Cranial nerve 6 is your abducens nerve. This is a long, windy nerve. The abducens nerve pulls the eye out. It allows you to look to the right or look to the left. And the take-home message on that is that because it's a long, windy nerve, if you have a mass expansile lesion in your brain, you're going to be cross-eyed. Why are you going to be cross-eyed? Because your medial rectus is going to be pulling you in, whereas your abducens nerve cannot work. And that's known as an abducens palsy, and that's associated with an intracranial mass. Okay, so if you see somebody sitting waiting for the scanner and he's cross-eyed, get him to the scanner quickly, because he could have a mass in his head, because what you're seeing is an abducens palsy. Cranial nerve 7, we talked about. Cranial nerve 8 is the acoustic nerve, has to do with balance and also being able to hear. Now, 9, 10, 11, and 12 are in the medulla, okay? These nerves have to do with lower function of your voice box and of your being able to swallow. 9 is the glossopharyngeal. It allows you to swallow. 10 is the vagus nerve, which we know about has a wide field of distribution. That's where we attach our vagal nerve stimulator. Cranial nerve 11 is the sternocleidomastoid that allows you to move your neck. And cranial nerve 12 is the tongue. The hypoglossal is the tongue. So the old rule of thumb, the old pimp question on this, what if you have a VA patient that comes in with ataxia, he's drooling, he may have a Horner's, but where's the lesion there? And the answer is he has a Wallenberg syndrome. What this is in the medulla, these nerves, nuclei line up. They line up on the side like this in the medulla. And also what's here is the spinocerebellar tract. Anytime you have cerebellum involved, you could have ataxia. And so you have a patient that can't control his tongue, he can't swallow very well, he's drooling, and he's got ataxia because the spinocerebellar tract is on the lateral end of the medullary region, which is known as the Wallenberg syndrome or lateral medullary stroke. Whereas if you had weakness, you would then have middle medullary syndrome. It would be in the middle here. Okay, why? Because the cortical spinal tracts run in the middle. They don't run on the side. And that's why you have ataxia and not weakness. Okay, so this is kind of a first glance at neurology and how things are kind of connected and how things are different in the world of pediatric neurology compared to adult neurology. And I'll take any questions now. No questions?
Thank you so much, Dr. Sokol. That was amazing. We've been getting a lot of positive feedback in our chat box that they think that you need to have your own YouTube channel and that they would subscribe. Everybody loves your animation, your drawings, and for making this work. So I haven't seen any questions on the chat box. Does anybody have anything that you'd like to ask her? If so, please unmute, show your video if you want. Feel free to interact. It would be great.
Okay, have a good day. Have a good lunch.
Dr. Sokol, I had one question. Sorry, I was slow to get my mute undone.
Okay.
I was going to ask, when you were talking about the early development of the brain and how the intraventricular hemorrhage occurs, is it most common for that area that affects the central, like mid-central CZ area to be the first area of malformation?
Yes, and sometimes you can see a positive spike with that instead of a negative spike. That's a good point. That can mean that that ventricles are getting bigger.
Thank you.
Hi, Dr. Sobel. This is Nessa Nicolaitis. When we're doing intraoperative monitoring and for a cerebellar pontoon angle tumor, we often will have a deterioration or EMG activity of the abducens nerve, and very often do we see that unable to deviate or gaze to the lateral aspect. So is there something with the abducens nerve wrapping around cranial nerve 7? Is there some sort of, why is it probably one of the most common injured nerves during those cases? Is there any neurological explanation?
Well, the purpose of the nerve is to move the lateral rectus muscle to the right or the left, really to the right. That's the purpose of the nerve. That's all it does. It just has such a wide fetal distribution, it can get hurt in many different arenas.
All right, because often I've heard that some of the surgeons say that it's the least myelinated of the cranial nerves. I don't know if that's actually a, I
don't know about that. Yeah. I don't know, but I know it's one of the longest cranial nerves.
Right.
Okay, thank you.
Thank you so much, Dr. Sokol.
Heidi Hawkins, what's he?
Oh, Heidi Hawkins, can you talk about the difference between myoclonic jerks versus myoclonic seizures? Where do they originate?
Well, myoclonic seizures are from the brain, right? Because the cortical, that's where seizures occur. But myoclonic jerks come from the brain stem, some people think. And some people think that like when you're on your last leg, then you see these myoclonic jerks from the brain stem. That's usually an ominous sign.
Okay, good. Anybody else have any other?
It means you're checking out, Heidi.
Okay, I don't see any other questions. I don't hear anybody else. So I think we can conclude with you. Thank you so much for your time, Dr. Sokol. It's great to see you.
Okay, bye.
Thank you. Great job.
Okay, so